morning to this Cleft series titled Strategies to Address Nutrition in Comprehensive Cleft Care. Moderating with me this morning is Comrade Olubumi. Moderating with me this morning is
Dr. Olusanya, are you there with me? Mrs. Comrade, could you please step on? Yeah, it seems like we are losing Dr. Olusanya. Thank you.
Okay. Thank you once again. Thank you everyone for joining us this morning. And I'm sure we're going to enjoy ourselves while we, I step in, await Dr. Olusanya. So once again, my name is Comrade Bumi Lawan. It's a great pleasure to meet us this morning. And a big thank you to Smile Train for giving us this opportunity to discuss what is very, very important to the growth and development of our nations all over the world. So we have wonderful, wonderful panelists this morning that will be discussing this important issue with us. And the first person I would like to introduce is Miss Miriam Neville, who is a clinical nutritionist from Dreamland Mission Hospital in Kenya, all the way from Kenya. And I will also say that she's a nutritionist and of course a dietitian from the University of Eastern Africa, Baraton, and currently provide nutrition rehabilitation to parents with various medical conditions, including and principally cleft lips and cleft palate. Miriam's teams ran the first Smile Train pilot cleft nutrition program in East Africa. And in the last couple of years, she has been instrumental to rolling out the Smile Train spoon cleft nutrition curriculum through the training program in Kenya, Tanzania, and Peru. Thank you very much, Ms. Miriam, for joining us this morning.
Thank you, my moderator, Comrade Olubumi, for saving the.
Over, ma'am. Over.
Dr. Salam,
Dr. Adiola, are you there? Okay, so quickly, let me, it also gives me a pleasure to introduce to you one of our renowned pediatricians right here from Nigeria, Dr. Abdul Salam Muhammad, who is currently an associate professor of pediatrics at Bayero University, Kano State, of course, in Nigeria. And of course, is a consultant neonatologist, pediatrician at the Americano Teaching Hospital. You are welcome, Dr. Abdul Salam. Our next panelist is someone I admire so much, very young and vibrant, trust me when I say that. And she's by name Matsida Amuffa. She is a nutrition officer at Comfort Anoye Teaching Hospital in Ghana and a member of the Cleft team. Our duty is to adequately prepare the cleft parent or the cleft patient for surgery as far as their nutrition is concerned. Our goal is to enhance our skill and contribute to the growth and development of these children and to bring smile on their faces. Wonderful. You are welcome, ma'am. Yes, so our next panelist, and very, very committed, someone I also really celebrate a lot. She's by name Mrs. Achioma, who attended University of Nigeria, Nsukka, Nigeria, from the year 1998 to 2002, where she studied human nutrition and dietetics and graduated with a Bachelor of Science degree. She did an internship at the University of Nigeria Teaching Hospital, Enugu, after a National Youth Service Corps in Oyo State. Mrs. Achoye has worked at Mother of Children Specialist Hospital, Enugu, and is presently working at National Orthopedic Hospital, Enugu, as a dietitian since 2006. You are very welcome, madam.
All right. Thank you. Thank you, comrade.
You're welcome, ma'am. Over.
Yes. So we will have the panelists' presentations now on topical issues, and following that, they will share their various experiences from their institutions with us. So over to Ms. Miriam Neville now. We'll have your presentation for 10 minutes. Thank you.
Thank you very much, Comrade Olobumi, for introducing me, and thank you, Dr. Adeola, for also inviting me to this platform. So if I could just share my screen. Okay. Are you able to see my screen now?
Yes, we can.
Great. Thank you. So our topic, as we have been introduced and as it has been introduced to all of us, is strategies to address malnutrition in comprehensive cleft care. And I just have a very simplified overview of how we'll run through this topic. I will take us through the overview of comprehensive cleft care and the burden of malnutrition in children with cleft. And then I will have our next presenter, Dr. Mohammed, taking us through the significance of nutrition in the cleft journey. And then Ms. Matsida Amuffa will take us through the feeding techniques in cleft care. And finally, we'll have Mrs. Edna Achinoye, who will be taking us through the strategies to address malnutrition in cleft. And so as our introduction, if I could just speak about Smile Train briefly. Smile Train is an international children's charity that is focused on treatment of children with cleft lip and palate. I'm sure we all know that. But besides that, Smile Train works with a vision, which is a world where every person has adequate access to high quality, comprehensive cleft care and is able to live a fully and a healthy life. And Smile Train does this through committed treatment of the whole patient through programs that provide access to important comprehensive cleft care services. So if we could just look briefly into what these comprehensive cleft care services mean. The comprehensive cleft care is intended to ensure a long-term successful rehabilitation for cleft patients, and it includes essential treatment that is beyond the cleft surgery. We might have heard about other organizations that are involved in cleft treatment, but Smile Train in particular uses an approach that goes beyond the surgery. And so there is the diagnosis and understanding of a cleft, where we healthcare providers, community volunteers are empowered on how to identify that this is a cleft of the lip, a cleft of the palate. And then for such a child, the next step would be feeding and nutrition, meaning they are able to be enrolled to partner hospital where they can get the comprehensive nutritional care. And then once they attain their required nutritional status to mean their weight is okay for their height and age, then they can have surgery, And then beyond surgery, there is the dental care, there is the ENT services, there is the speech services, then there is the orthodontics, and there is counseling and support for all done to these patients to be able to ensure that despite them being born with a cleft, but still they can be able to have access to all these necessary services, and in the long run be able to grow normally as a normal child. And therefore this comprehensive approach is only possible because Smile Train model is focused on empowering local medical professionals and health systems to be available for families that are affected with cleft every day, all year round. And so if we now proceed to focusing on our area of feeding and nutrition as one of the pillars in the comprehensive cleft care, we understand that feeding and nutrition is the first and most important step in the cleft care journey. Because in the first place, we have to ensure that the children are well, strong enough, and ready to be able to undergo the cleft surgery. And so feeding is very key in this care for the cleft children. And this difficulty in feeding is one of the most critical problems that normally parents of cleft babies, they face every day. And it's because of the nature of the cleft. Normally it makes it difficult for the child to be able to suck, which means they can be able to get their normal feeding like every other baby, because we understand breastfeeding, they need that suck. Using a bottle, they need that suck. And so it may be hard, especially in the first few days. And this causes very tremendous stress to the parents after birth of their baby with a cleft. And so in ensuring adequate nutrition from birth is the first priority in supporting these mothers to be able to overcome the difficulty of feeding for their cleft babies. And newborns vary in the way they cope with that cleft. Depending on how the cleft presents, they have different challenges. There's one who will be able to breastfeed. There's one who would really struggle to breastfeed. And so we have to understand the differences, and then it will help to be able to know now the different techniques that you can use to support each one of them to be able to feed. And so making adjustments can help to go a long way in helping these infants who have difficulties to be able to attain their adequate nutrition. And as we go along with the presentations, we'll see those different adjustments that could be made for different children. And so these adjustments normally focus on making sure that breastfeeding is initiated, or at least the production of breast milk is initiated and maintained so that the mother can be able to breastfeed, if possible, directly from the breast. But when that is not an option, then we can still be able to encourage the mother to express and feed their baby on the right milk at the right time with the right equipment, whether it's a spoon, a cup, or a bottle, but what is ideal for that baby to still be able to maintain a good nutrition. And so in resource limited settings, regardless of whether the baby has a cleft or not, non-breastfed infants are up to 25 times more likely to die of diarrhea than breastfed infants. Of course, because of introduction of other feeding equipment, the cups, the spoon, they require a really high percentage of hygiene and care when taking care of these children, which has to be accompanied as part of the counseling when you're giving to the mother. And also complementary food and liquids other than milk are often introduced much earlier than it is recommended. We know what WHO recommends is breast milk up to 6 months exclusively, and then going forward to 2 years. But we'll see, is this an option for clefts? Is it a possibility or is it not? So basically, from just a child who is born with a cleft, it is clear that that timely initiation of care for this child, which means immediately a child is born with a cleft, the mother can be able to receive the necessary care and counseling to support this child. The mother can be taught on how to breastfeed this child. If not, the mother can be taught on how to express and still provide her milk to the child. It's directly goes hand in hand with how early this child will be able to receive their surgery, how early this child will be able to attain their normal growth curve and therefore be able to progress with their development and surgery and recovery. And it's so to say, once that is also delayed, there is no prompt support and feeding counseling, then if that is not the case, then that child will definitely be at a very high risk of being malnourished. And even beside the prompt counseling and support, there has to be a growth monitoring step in between, meaning the child can come, do a weight, a height, a mark, or a length, see how that is comparing to the standard and proceeding into what's next, how to support this child next until they are able to maintain or achieve a normal curve. And therefore, an unrepaired cleft, just what we have said, makes it difficult to breastfeed. However, with timely and appropriate care, that can help this child to be able to breastfeed. But if that is not put in place, then it will directly lead to the malnutrition of this child, because then they are not well fed, they are not able to grow well, they're not able to meet their optimal nutrition status. And once that happens, then for such a child, it means the surgery will definitely be delayed. And the more we delay the surgeries, the more the other complications arise of speech complications, the more the child will need specialized orthodontics after the surgery, the more the dental care will be poor, the more the ear infection. So there's just all there's a lot around malnutrition and the delay of surgery for such children. And if I just highlight, why am I really talking about malnutrition when you're talking about these cleft children? It's because a study was done, and this study was comparing the children under 5 years who have clefts and children under 5 years who do not have clefts. And if you could just see, it may be a bit unclear, but I hope you can see. The blue dots represent the children who have clefts. They are on the SmileShine database, and therefore this is just a table to show the underweight of children among clefts and the non-clefts. You could see the blue dots are higher than the orange dots. The orange dots are the most recent data of undernutrition in the respective countries. And if I could just pick a few, like if you see Nigeria has about a 40% undernutrition for underweight for cleft, and around 30% underweight of non-cleft. And Kenya, for example, has a 30% undernutrition or underweight status for cleft babies. And according to the most recent, which was in 2014, there's about a 15 or 12, at least 12.5% of children who do not have cleft. And it highlights various countries, which when it was compared for underweight and among the cleft and the non-cleft, it's very evident that within the cleft population, the underweight is much, much higher than that of the underweight children. And this next curve is just a comparison of the wasting and stunting, which is a classification of malnutrition, and it's not, underweight is basically a weight for age, and it does not tell us much about what is going on with these children. But wasting is more specific, and stunting, like a wasting is a weight comparing a weight and a length, or a weight and a height, and a stunting is comparing a height and an age, or a length against an age. And so you could see that in the green, out of a data down to 14,000 children under 5 years, the green, which shows 57%, this shows that those children, they are neither underweight nor stunted. However, meaning that their weight for their age might be okay. But however, when you go ahead to see the same children, if you look at their weight and height, or their height and age, that is their wasting and their stunting percentages, you'd see that out of that, 30% are short for their age, or 11% are both short and are wasted. They are wasted, meaning they have an acute state of malnutrition. And so this is still data done to cleft children at their first presentations, showing up in cleft partner hospitals, smile-trained partner hospitals that offer cleft care. And so it's still evident that malnutrition is still on the rise. It's still very high among our cleft population, and there is something, or there's a lot that we need to do out there in our respective facilities to be able to cap these percentages of malnutrition among our cleft population.
Thank you, Miriam. Thank you, Miriam.
Yes.
We might need to take on the next. We might need to round up now for the next presenter.
All right, as I conclude, I think this is just about my last slide. The implication of malnutrition, like I said earlier, is just beyond the delay in surgery. And so malnutrition could lead to various other issues like speech impairment, chronic ear infections, and even possible hearing loss. And therefore, beside that, there is still malnutrition, which still makes the life of that child at stake of death. And so when we go forward, we'll look at what happens to this malnutrition. Is there anything we can do to prevent it? What happens to our cleft children? What are we doing in our respective hospitals to be able to deal with that? So I'll stop it at that. Thank you very much.
Thank you very, very much. That was very educative. We'll now take on Dr. Mohammed Salam, who will be talking to us on the significance of nutrition in cleft journey. Dr. Salam, sir. Dr. Salam, over to you.
Can you hear me now?
Yes, we can hear you.
Okay, let me put the slide
Welcome,
on
Dr. Salam.
Thank you. So, good day, everyone. All protocol observed, I would like to extend my sincere appreciation to SmileTrain for giving me this opportunity to speak on the significance of nutrition and cleft journey. And I will go by this preamble. Now, we all know adequate nutrition is essential in early childhood for growth, proper organ formation, strong immune system, good neurologic and cognitive development. The growth and development of children with clefts need a lot of care through good nutrition, especially during the growing years. And economic development or economic growth and human development of any nation depends on well-nourished populations. And therefore, child malnutrition impacts on cognitive function and contribute to poverty through hindering individuals' ability to lead productive lives. It is crucial to implement right nutrition intervention and educate caregivers to attain optimal health in children with clefts. By way of definition, nutrition is the process of taking in food and using it for growth, metabolism, and repair of tissues through the stages of ingestion, digestion, absorption, transport, assimilation, and excretion. Infants with clefts share the same nutritional growth requirements as normal infants. However, additional calories may be required when other systemic issues are identified. Now, feeding difficulties of infants with clefts need immediate attention to ensure adequate nutrition and minimize complications such as malnutrition. Now, initially when the infant is born, anthropometric measurement of the weight and height, as been said in the previous lecture, are recorded and plotted for age-appropriate parameters. And then after the initial weight loss during the first 2 weeks of life, a weight gain of 15 to 30 grams per day is expected. Now, adequate nutrition during the first 1,000 days window of opportunity is critical in preventing long-term irreversible damage to child health, cognitive, and physical development. So good nutrition is especially important in infants with clefts. And good nutrition in cleft infants help build their resistance to infection, help them to withstand surgery, and to also have the nutrients needed to heal after the surgery. However, for infants with poor weight gain, breast milk can be fortified or higher calorie formulas can be used to meet the nutritional requirements. Now, there are 6 good rules or 6 rules for good nutrition, which have been identified. And these are: ensure pregnant mothers have adequate nutrition, promote exclusive breastfeeding up to the first 6 months of life, and then continue with regular breastfeeding up to the age of 2 years. Introduce complementary feeding at the age of 6 months based on the AFAS and FADUSAM criteria. Continue feeding when the infant is ill. Prepare, cook, and store food correctly, and avoid harmful or inappropriate foods or inappropriate feeding practices. There is no substitute to human breast, not even the most advanced formula. It cannot provide the advantages or the benefit provided by the breast milk to the babies. Breast milk provides infant with well-nourished or well-balanced mixture of amino acids, sugars, and fats. Vitamins, mineral enzymes, and prebiotics found in breast milk aid digestion. Breast milk has high levels of cholesterol to support brain growth, hormone development, vitamin D synthesis, and bile production. There are antibodies found in breast milk which also strengthen the baby's immune system and decreases risk of infection. What are the stimulus or stimuli to the breast production? The key stimulus to breastfeeding is actually the infant suckling. And the more the infant suckle, the more milk the mother produces. And this is where the problem is in infants with cleft, actually. On the average, a well-nourished mother will produce between 750 to 800 ml of milk, breast milk per day. Now, there are also some guidelines that have been established, guidelines for breastfeeding in infants with cleft lip or cleft palate and lip. Number one is breast milk should be promoted above formula feeding. Mothers should be told that sole direct breastfeeding may not be successful, and therefore strategies to establish and maintain lactation should be learned, as well as how to transition to direct breastfeeding when able. An infant's ability to breastfeed should be evaluated on individual basis. Babies should not be compared, actually. They should be evaluated on individual basis. Now, knowledgeable support and early access to lactation specialists should be sought. And then monitoring the infant health by assessing hydration, weight gain, all are critical with breastfeeding and balance with supplemental feeding if necessary. Now, these are the breastfeeding guide. And breast milk should be promoted above formula feeding. Okay, talking about bottle feeding now. Bottle feeding can be made easier by using a normal teat with an enlarged hole, making the hole to be cut at least cross-cut hole to make it larger to improve the free flow of milk. Special teeth can be made available if they can be afforded, if an infant is having difficulty with standard teeth. Positioning an infant differently may also help with feeding. Using upright position prevents fluid from entering the nose, what we call regurgitation. We have to also remember that every baby is different. A number of different methods may be tried before finding one that suits the baby. These are some of the feeding problems associated with the clefts, actually, ranging from the insufficient suckling, escape of food into the nose, leading to various complications, such as fatigue, inadequate milk intake, excessive air swallowing, resulting in irritability, hunger, poor weight gain, and malnutrition. Or escape of food into the nose can lead to aspiration, nasal regurgitation, coughing and choking, and sometimes even respiratory tract infections. Some studies have been conducted that are actually associated with malnutrition in patients with clefts. Found out these factors are associated with malnutrition in this cleft patient, maternal age of less than 25 years, probably because of ignorance or inexperience in these mothers. Low maternal education, especially those with only no primary or just primary level of education. Lack of post-delivery information on infant feeding played a role in actually the malnutrition in cleft patients. Feeding pattern. Some insist on breastfeeding, while if it is a cleft baby, breastfeeding may not just be feasible. And that baby, if you depend on just breastfeeding, baby can actually be malnourished. Number of feeds per day, less than 10 feeds per day have been shown to be associated with malnutrition in babies with clefts. So also age of what? Less than 4 months, because of inability of these babies to latch on and get attached to the breast and suckle properly. Female gender has also associated with malnutrition. This is because in some cultures, attention is more given to the male child, and therefore female children are just taken probably when the problem gets worse. The birth weight of less than 3 kilograms has also been associated with malnutrition in cleft babies. So also association or presence of other congenital anomalies, such as congenital heart diseases. Category of the cleft, unilateral cleft. This is because patients with bilateral clefts actually seek medical attention or the advice of the healthcare providers early compared to those with unilateral clefts. So feeding difficulty not only compromise growth, but can also affect maternal attachment and the decision to continue breastfeeding. The milk supply of the mothers with clefts infants may decrease due to inconsistent or difficult breastfeeding decision. There was a study of 200 infants. The infant's ability to create normal suction contributed to mother's decision to stop breastfeeding in nearly 80% of cases. In another study, 70% of mothers stopped breastfeeding due to inability to latch on to the breast properly. So given the significance of breast milk, when mothers are unable or unwilling to breastfeed, they can be supported to express their breast milk for bottle feeding. These are some of the different types of feeders or nipples available for cleft lip and palate infants, just to show. It is considered that the infant's first immunization, we are now talking about the benefits of the breast milk. It is considered the infant's first immunization as it offers baby protection before baby's own immune system develops. Docosahexaenoic acid is a major component of brain tissue, and it has been shown that children who have consumed their own mother's breast milk cannot be compared in terms of the intelligence quotient at 7 to 8 years. Now, the other nutrition benefits and growth and development benefits. Breast milk provides infants almost all nutritional needs from birth, ranging from vitamins, protein, fats. The composition of these minerals or of these nutrients is actually unique, hence specific properties. The breast milk is more readily digestible, contains a lot of essential fatty acids, amino acids in good composition, and it also enhances visual maturation. Protective benefits. Breast milk has protective benefit in terms of infection, be it bacterial, viral, diarrheal diseases, or respiratory tract infections. It also protects against allergies and metabolic diseases later in life, such as diabetes, asthma, or eczema. And it also lowers the risk of obesity and some cancers in the baby. Now, it also has some benefits to the mother, contraceptive benefits. It also helps the mother to run or to return to her non-pregnancy weight faster. It also helps the mother to actually have a reduced risk of postpartum hemorrhage. It reduces also risk of cancer and other cancers that women do who do not breastfeed. Economic benefit. It is has less expenses on infant formula.
Because the amount of be rounding up soon.
Yes.
Okay. Thank you.
So benefit to the environment and the community and to the family. All right. So in conclusion, breast milk remains the best source of nutrition for both babies with clefts and normal babies. In the absence of breast milk, age-appropriate BMS, breast milk substitute can be recommended alternative. Adequate macro and micronutrients are essential for optimal growth development of children with clefts. Feed should be prepared and administered in infant with cleft in the most hygienic way to avoid infection. Complementary feeding should be introduced from the age of 6 months and continued with breastfeeding or BMS up to the age of 2 years. Just some few recommendations. Proper nutrition information should be provided for all mothers with cleft infants. The nutrition information shall include method of assisted feeding, feeding techniques, and follow-up, and then studies to assess different modalities of assisted feeding so as to come up with the most applicable method for our caregivers to adopt. Increase public awareness of malnutrition for infants, both with cleft palate. This will emphasize nutrition for both caregivers and care providers of these infants. There are also need for studies to assess the role of culture in assessing healthcare in respect of infants with cleft conditions. And there's also a need for more cleft care support groups from both private and public sectors. Thank you for listening.
Thank you so much, Dr. Abdul, for yet
references.
another lovely presentation. We'll now quickly go on to Ms. Matsida Amuffa for feeding techniques in cleft care. Ms. Matsida, please.
Okay, thank you, Dr. Adiola. Could you please help me share my slides?
Yes, I'm sure the technical team, if they're on it, they'll be sharing some.
Okay.
Miss Matilda, please go ahead. You are enabled to share your screen.
Okay. Is it okay?
It's not in full screen yet.
Yeah. I'm kind of lost on how to do it.
Miss Matilda, are you there?
Miss Matilda, I think we're off wow. Maybe we'll take her. Give her.
In doing that in a full screen. Hello.
Hello, we can hear you, but I think your internet
is sharing it like if you have it.
Hello. I think Mrs. Edna Achinoye, if you're ready, we'll probably take on yours while we wait for Miss Matilda. Mrs. Edna. Mrs. Edna Achinoye. I think she's not ready yet.
Miss Matilda, please let me share your slide so that you can just guide me to move slide by slide. Is that okay for you?
Unmute yourself, Miss Matilda.
I'm going to share your slides. Yes, it's better. And then you can stop your video. It seems like your internet connection is not very good. Maybe it will be better if you stop the video. Yeah, thank you.
Okay. So, as rightly introduced, I'm Matsida Amuffa from Confanochi Teaching Hospital, Ghana, and I'm presenting on feeding techniques in cleft lip and palate. Please, next slide. Next slide, please. So my outline for this presentation is we have introduction, breastfeeding positions, and then the feeding systems that are available for these children. Introduction. One of the most critical problems faced by parents with cleft babies may be difficulty in feeding. Before surgery, the cleft may affect the action of sucking, which is very important as far as feeding is concerned. Cleft lip makes it hard for babies to make a good seal around the nipple. That is the latching. Not all the babies with cleft lip, but a few of them are not able to latch on very well. And then on the cleft palate, it also makes it difficult to create suction, which is needed to pull milk from the nipple or the feeding bottle. A baby who is put to their breast may look like they are latching on and sucking well, but they are using up energy and getting little or no milk. So that's the difference between the lip and then the palate. One is able to latch on to the nipple very well, but not able to suck or suckle. And then the other one, when given the opportunity to suckle, will be able to do it very well, but then is not able to latch on very well. So even though babies with cleft has normal sucking and swallowing reflexes, they need special bottles and techniques to feed well. And these special bottles allow the flow of milk without necessarily sucking from the nipple. It is rarely possible to breastfeed or use a regular bottle, especially in the case of cleft palate. Next slide, please. Okay, so these are some of the breastfeeding positions. It goes well with babies with cleft. So the first one, we have the modified cradle hold. This position kind of works best for bilateral cleft patients, unilateral cleft patients. They are positioned, their nipple is positioned away from the cleft so that there will be no difficulty as far as the sucking is concerned or latching is concerned. And then we have the modified football hold. This position helps the bilateral cleft babies. The infants are kind of positioned in an upright manner. It allows the mother to hold the baby's head, allowing the baby to latch very well. And then we have the dancer hand position. The infant's chin rests in between the thumb and the first finger, which helps stabilizes the jaw, whilst the rest of the fingers are placed under the breast. So these are some of the breastfeeding positions that, when taught, will allow mothers to breastfeed very well. Please, the next. As I first said, the cleft lip, their problem is latching on. And so if their mothers are taught on ways of positioning them when breastfeeding, they will have no problem as far as breastfeeding is concerned. And so there wouldn't be the need for bottle feeding. But with the cleft palate babies, they are not able to suckle. And so they need the bottle feeding. There are special bottle feedings available for them. So what you have to do during the feeding is to place the baby in an upright position to prevent milk from flowing back into the nose, which is the nasal regurgitation. You keep the bottle tilted so the nipple is always filled with milk. And then the child will not have to struggle to suck the nipple. While you also point down the nipple away from the clefts. When you do this, your baby will be able to move the nipple into the most comfortable position for him or her. Infants are able to adapt quickly and very well. And so when given the right combination of positioning, technique, and then support the mother, giving the mother information, these children will grow and thrive. And the one thing about the feeding bottle is, if the specialty feeding bottle is not available, there are other solutions to achieve effective feeding. Like the first slide that was shared, there was this one feeding bottle with a spoon attached to it. The child will not need to suckle before getting the milk. You can also modify the nipple of the feeding bottle, making some cross-section at the tip of the nipple to open up the space or the opening of the nipple a bit so the child will not struggle whilst bottle feeding. So that is it. Thank you.
Thank you very much, Ms. Matsida Amuffa. Thanks for the presentation. We will now welcome Mrs. Edna Achinoye, who will be talking to us on strategies for addressing malnutrition in cleft care. Before we have the second segment of this seminar, which will be on sharing the panelists' experiences from their various centers. Mrs. Edna Achinoye, you're welcome. Ms. Achinoye. I think we'll probably start taking the experiences of the panelists from their various centers. So I would invite Ms. Miriam Neville, if you can just take your aspects while we wait for Ms. Achinoye, so that we'll be able to buy some time. Ms. Miriam, please, can you come on? Ms. Miriam Neville.
We seem to have lost Miss Miriam. We can proceed.
Okay. Dr. Salam.
Yes, ma'am.
If you don't mind, sir, can you share your experience with strategies that you have used in your centers, those that have worked and those that have not worked? What your experience has been generally in your center?
Let me go to my. I have the experience here. Let me share them.
All right, thank you very much.
Just a bit of. Yep. So let me put it on the slideshow.
Okay.
No, next one. So these are experiences actually. So, but before I proceed with the experiences, I would like to actually highlight the profiles of our patients.
Okay.
Yes. So most of our cleft patients are actually from the rural areas, about 70% and above. And majority of these parents are poor with many other children. And many of them have many misperceptions about clefts. So some feel that the mother or the father has done something wrong to warrant having child with clefts. And some mothers are themselves malnourished, hence do not have enough breast milk. Some mothers do not want to breastfeed the infants for obvious reasons, probably stigma and what have you, while others do not know how to breastfeed infants with clefts. So these are some of the problems. Now, what we do when we have infants with clefts, we first of all counsel the caregivers and dispel the misperception about the babies with clefts. Now, make use of syringe. We actually make use of syringe in feeding the babies and teach the caregivers how to prepare and administer this feed as either express breast milk or breast milk substitute with the syringe. Now, the syringe is changed with a new one on daily basis. Hygiene in handling, preparation, and administration of feeds are emphasized. Caregivers who are poor are supported by Smile Train and given breast milk substitute free of charge. Those that can afford the BMS are encouraged to buy and taught how to give it using the syringe. Now, the indigent caregivers are also supported with transport money to enable them come from the rural areas. I told you most of them are from the rural areas. They are also empowered by the Smile Train to engage in petty trading to make them self-reliant. This is what is being done in our center. Now, during the complementary feeding, poor caregivers are also supported with infant cereals free of charge by the Smile Train. While those that can afford are encouraged to buy or prepare locally available foods for their infants. Also, uncomplicated ailments are also treated free under the support of the Smile Train. Patients' anthropometric parameters such as the weight, the height, and the mid-upper arm circumference are monitored at regular intervals and compared with the reference charts. Now, so in summary, what we engage in is actually capacity building for mothers and caregivers, capacity building for caregivers, development of educational videos, nutritional programs, and empowerment programs. These are our experiences and what we are doing in our center. And probably this might have led to us having the highest number of Cleft patients in the country from our center, because these things that we are doing motivate them to actually come from the rural areas. We also liaise with TBAs to help us identify these cases earlier and refer them to us for onward management. Thank you very much.
Thank you so much, Dr. Salam. That's a very encouraging story that you have given us. Comrade Olubumi, I don't know if you have any comments on that.
Thank you very much, Dr. Wadi. And I want to say a very big thank you to our participants. We are about 51 now. It's been interesting discussing strategy to strengthen nutrition in comprehensive cleft care. Trust me, I've enjoyed myself today, and I'm sure you have too. And you know, one thing that is very important and is strategic in this discussion is the fact that malnutrition is a critical problem. Malnutrition is a major problem. Even for children that do not have either cleft lips and cleft palates. We all know that 45% of under 5 deaths actually is attributed to malnutrition. We can imagine that. And quickly, I want to share statistics with us by WHO that says that globally, 47 million under 5 are wasted. 144 million under 5 are stunted. These are major problems. And these are children that do not have cleft at all. Not talk more of our children under 5. They are vulnerable by their age already. They have orofacial cleft. And that is why we cannot but to appreciate the intervention each country, each centers are doing, powered by Smile Train. Thank you very much. Having said that, I also want to yeah. So I will say that I also want to say that comprehensive cleft care, as we've heard today, is so interesting to know that it's actually beyond surgery. So we need each other to support these patients. Just like what Dr. Salam have pointed out, we must from day one, these children deserve the breast milk. We also mentioned the importance of early initiation, putting this baby to breast in the first hour of birth. So because this child has cleft, does not deprive this very baby from the breast milk. And that is one area that I really want us to look at. So we can actually help the mom to express, to support, to talk. And again, I want to also appreciate Matsida that talks about the different positioning, because we all know that positioning and latching actually play a key role when we are feeding baby and preventing malnutrition. So she talked to us about the modified cradle hold, which is very important. It's just like the normal cradle hold, but it's modified. So this child with cleft is still a little bit up than the non-cleft baby. We also have modified football hold, dancer positioning. All of these are just to help. And with the experiences, like some years ago in XCBU, we know that when these women come to our facility, is a major concern. They are anxious. They are worried. Some of them have been rejected and denied, even in the community. And that is why one of our panelists has requested that, yes, I think we need to also do some study that shows that describe the cultural influence about nutrition and our cleft. So I really want to say thank you for joining us today. And we cannot do it alone. We need to join hands together to take care of these children. They need us. A child should not die just because he have orofacial cleft. A child is not supposed to die just because of malnutrition. No. And that is why I want to say a big thank you to Smile Train and all our panelists today. And once again, I want to call on Matsida, who has spoken very well, very eloquently, to talk to us. What is the way forward? We know that nutrition is a major challenge for everyone. We know in different countries. It's just in different shape and different sizes. But what is the way forward from your own experience? What are the best practices? Just like Dr. Abdul Salam have also shared his own success story. Can we hear from you, Matsida? Over, please. Thank you.
Okay, thank you. Thank you, comrade. We have something here in Ghana we call start right, feed well, or eat well. And then as these babies are born, starting right, of course, start with early initiation of the breast milk. And so breast milk is very, very important in our lives, especially where we have a number of them coming from poor homes who cannot afford the infant formula bought out there. So what we normally do is sometimes before the mother presents the child to you, because of that anxiety and the stress and all those things that comes with having a cleft baby, the breast milk somehow begins to withdraw. I don't know if I'm using the right word, but it's kind of cease. And so what I normally do is try to re-establish the breastfeeding. Those who are able to suckle very well, make sure the mother does it, or we teach the mother on how to do it to establish the breastfeeding. After, what we normally do is, after the child suckles, we ask the mother to do express breast milk. So you don't just allow the child to suckle and then that is all. After you think the child is somehow has gotten enough, which may not be enough, but to you, the mother, you think it may be enough. So we advise that the mother do express breast milk and then do a top-up to be able to make sure the child gets enough. For the cleft palate children, here in Ghana, we don't advise using feeding bottles. It's out of the question because of hygiene. You may talk to them several occasions concerning their hygiene practices, but then when they go home, they do their own thing. So we advise strongly against it. So if either the mother uses a cup, and then the syringe, if you are admitted, fine, you will get it. But we can't get enough syringe for you to take home. And so that one is also out of the question. We have this cup, I don't know if we call Nifty cup. We normally share it for the mothers to use. So we have this pointed tip here. The child is able to get enough at a time. The liquid that comes from the cup itself to the point here is just enough at a time for the child. If this is not available, we encourage cup and spoon feeding. But one thing about the cup and spoon feeding, and this one, is that this one kind of reduce spillage. So you are sure the child is getting enough. Where you've asked the mother to give 40 ml per feed, using a cup and spoon, at the end of the day, about 5 to 10 ml will spill. And so the child may not get enough. But with this Nifty cup, which is available to us here in Ghana, you are sure the child will get all the 40 ml. And then you also encourage the mother not to wait till the child is about breastfeeding before she goes in to do the expression. At least some few minutes before time, the mother will have to do the expression. Allow the child to just play around the nipples to aid in stimulation and then the flow of milk. After which you give, though you are aware the palate can suckle, but we just advise the mother to just allow the baby to just play around the nipple so that it will help in stimulation, which will then allow more production of the breast milk. Whilst after the playing of the nipples, then you give in the expressed one. Without, you are able to maintain the flow of breast milk. Because to be honest, the buying of the infant formula, it's a huge problem. They tell you they can buy it, but after buying, if they are doing the feeding very well, at least one thing will last about 5 to 6 days. The mother will have to buy a new one. And when they realize they are not able to continue, then the amounts they are supposed to give to the baby, they tend to reduce it as a child reducing in weight. So we don't encourage buying of the formula, but we rather help them do the re-establishment of the breastfeeding wherever they have gotten. And then I think that has worked for us, yes.
Thank you.
Thank you.
Thank you very much. Thank you for sharing that experiences with us right away from Ghana. We really, really appreciate that, especially when you talked about the express milk. We all know that breast milk can be saved when you express it at the atmospheric air for 6 hours. It's still safe. So that is why we always encourage mom to actually express the breast milk to feed the baby. And you said something that is very important. The top up milk is very, very important. And we really encourage our mom with a baby with cleft or cleft palates or lips to express after feeding to still give top up feed to make additional so that the baby can have optimum nutrition. I want to say thank you so much. And I want to really recognize one of our own, I'll call our own Professor Adebola. Thank you so much for joining us. And our project director, thank you so much, NK Twale, thank you. And right now, I want to ask if Edna is online now. Mrs. Edna, are you online? Edna, are you online? Okay, finally from me, before I hand over to Dr. Adeola, I just want to say that yes, even in Nigeria, we also promote exclusive breastfeeding early initiation, and we frown with bottle. But you know, there are some difficult circumstances that we cannot help. And that is why we really appreciate Smile Train for always supporting, for always giving us all the backing that we need. In fact, if we listen to the experiences from Dr. Abdul Salam, you know that Smile Train is really doing a lot, not even in Nigeria, globally, I must say. And the issue around the infant formula, looking at the AFAs, is very, very important. The mother must, or the parent, or the caregiver must be evaluated based on AFAs. Is it available? Is it visible? Is it avoidable? Is it sustainable? All of this also must be considered before we can say, okay, let's place this child on infant formula. What we are saying today is there is the importance of nutrition, adequate nutrition in the cleft, especially when we talk about comprehensive cleft care. Thank you very much. And over to you, Dr.
Thank you, Comrade Olubumi. Thank you, Matilda, for that experience that you have shared. We've actually gotten a quite number of tips from what you have said. Thank you very much. Mrs. Achinoye, I'm not sure she's with us now. I would like to invite Ms. Miriam Neville for her experience at our center, if she can share with us. Ms. Miriam.
Thank you. Yes. Thank you very much, Dr. Adeola, for inviting me once again. And again, sorry, it disappeared. My internet just lost suddenly. Anyway, so yeah, if I share my experience about how the strategies we use to be able to address this malnutrition. Number one thing that we have tried to teach around and work around is first prompt referral of cleft children to hospital, where we can have our very fast intervention of being able to support the mother to attach and breastfeed. And so we have taken initiatives to go around hospitals within and hospitals that possibly refer to us children who are born with cleft. And we have taught the midwives and nurses there firsthand on how to position a baby with a cleft, how to encourage them and be able to confirm to them that it's still a possibility. Because once that is done, normally we lose it when we do not initiate it early enough. And by the time they're presenting and that is lost, then it's hard to reinitiate this child to breastfeeding. And so we do that. We are able to encourage the mother to position, teach all the different strategies as highlighted by Miss Matilda in her presentation. So we could try the cradle hold, we could try the football hold, or we could try the dancer hold and see which best works for each child and which the mother is more comfortable with. Then once that is done, we also try to be able to support the mother on expressing. We teach them the technique of press, compress, release, and repeat when they are trying to express their breast milk instead of just pulling it down the way everyone else tries to express. So with the technique, the mother is able to express her milk from the very deep breast tissues. And so it allows the milk production to be much more. For those who can be able to afford using a breast pump, we also encourage them to use, because for some they do not like the idea of hand expressing. But that has happened to a very low percentage of mothers. Most of them are comfortable with breastfeeding, with expressing, and so they support their breastfeeding session. First express on their hand, bring the milk closer to the nipple, around which when the baby positions, they are able to get the milk. And then after every breastfeeding session, they also express just to top up the milk, make sure the baby is very well fed, and also to empty the breast so that it helps to increase the breast milk production. And then we also support these mothers with very frequent follow-up visits to do growth monitoring, to be able to detect any deviation in their growth curve, and so we can be able to attack or intervene in case we see a possibility of a malnutrition coming up. And so every follow-up visit, we do sometimes 2 weekly follow-ups, 1 weekly follow-up, or a monthly follow-up, just to be sure we are keeping track of the child's weight and height and length at every follow-up visit, and we keep a growth curve for each child so that we are able to keep track. And in case there is a slight deviation, because we want a curve that tracks along the median or along the -1 or +1 Z-score, but when we realize that it's falling off, we start addressing and looking at what could be the issues around this condition. And then beside that, we also try to put the mothers in support groups so that they are able to listen to some of the mothers who have succeeded with malnourished children or with children with cleft, and they have listened to their stories, they have listened to their strategies and what they use. And so once they hear it from another mother, mentor mother, telling them about what they worked with, then that helps to encourage these mothers to be able to take care of their children well enough to prevent any possible cause. And we also discourage the idea of having a child who is malnourished because they have a cleft. We teach them how to not blame the cleft for the malnutrition, and in any case, to blame the care they're giving. So whenever there's a malnutrition, we're not talking about the cleft, because we're encouraging them to be comfortable with their babies with a cleft, because if they're positive about it, then it is easier to help them cope and deal or go around preventing that malnutrition, because they look at this child as a normal child, as a healthy child, and therefore it's easier for them to deal with such a child. So amongst those are the few that I may highlight, but I totally agree with what Matilda has highlighted. I'm sorry I missed out what Dr. Mohammed highlighted with regard to what they do in preventing malnutrition for their clients. Thank you very much.
Thank you very much, Ms. Miriam Nabi. That's pretty informative with what you have shared with us. I'm not sure Ms. Achinoye is with us, but we have two questions in the Q&A, and I think two of them are in. Can we have a translation?
Yes, I can help on that. In French, they said, selon les différentes expériences des différentes équipes, quelle appréciation faire du l'âge de plaques palatines dans l'alimentation des enfants avec fente palatine? According to the different experiences of the different teams, what assessment should be made for the use of palatal plates in the feeding of children with cleft palate?
Okay. Our panelists, I don't know if you've had any experience with, I guess the participant is referring to something like a feeding plate, like an acrylic feeding plate. In your centers, do you have any experience with that you'd like to share with us? Dr. Mohammed Salam, I don't know, do you have any experience with that?
Actually, in our center, we don't have any experience with the feeding plate, but I believe feeding plate is something that is used to snug in to actually cover the defect, especially in the cleft palate. Now, the problem with that one is something that can actually be tried, but that one is something that also has to be changed as the child is aging, as the child is growing. And also somebody needs to maintain a very good standard of hygiene to avoid also infection in such kind of situations. And another thing is, having said most of our patients are indigent patients who cannot even afford to use a feeding bottle. So affordability of the feeding plate is another thing. So I think these are some of the problem, probably these are some of the hindering factors that may actually militate against us using the feeding plates. Though we have not even tried one now, going by the profile or the socio-economic status of our patient, but I think that's where these are some of the drawbacks of feeding plates as far as our type of patients are concerned.
Okay, thank you. Miss Matilda, do you have any experience on that? Is she here? Okay, maybe you can have the last question, the second question, which is also in French. Can we address that? Before our time is up, we might still be able to take Mrs. Edna Achinoye's presentation if she comes in. Can we have the last question, please?
It's from the same attendee. He's saying, do the plates facilitate feeding for rapid weight gain, or are they just a protection for possible accidents in feeding children with clefts?
I think Dr. Salam has actually addressed the issue.
If I may comment still, I will actually say they serve both purposes. Number one, they actually occlude the cleft in the palate, thereby preventing aspiration and also regurgitation. Then number two, they actually enhance proper intake of the required amount of feed. And that can actually go a long way in improving the weight gain in the baby or in the child. I think they serve dual purpose.
Yes. Let me add to what Dr. Salam has rightly said. Obtaining a feeding plate is pretty technical, and it's usually from a prosthodontist in the dental profession. So it's pretty technical. Some measurements will have to be done, and then the fitting and adjustments, they are all technical. And it's not really a safe proof because it will occlude the cleft palate, but fluids can still go underneath it, and that also can cause some challenges, especially because the nose is directly opened onto the feeding plate, or is now not accessible to the oral cavity anymore. But then fluids can still go to the back because the feeding plate is a rigid material and would not move easily with the soft palate. Meanwhile, the palate will still be open at the soft end at the back. So the seal is also questionable. It's not a very common device that is used. I think I saw Ms. Achinoye, if she can still manage to give us her presentation on strategies before we bring this towards the end. Ms. Achinoye Edna, are you with us?
Yes, I'm with you. Sorry for all the illnesses.
Yeah, we understand. Thank you for joining us. If you can quickly go through your presentation on strategies to address malnutrition. We have roughly like 10 minutes to go. If you can just take that, would be very appreciative.
Yeah. Another device today, so I might not be able to show you my slide. Yeah. Hello.
Hello. You're breaking up, but we can see your slides. We can hardly make out what you're saying, Mrs. Edna Achinoye.
Can you hear?
Oh. Yeah. Hello.
Hello. Hear me?
It's breaking so badly. We can hardly hear you. If it's possible to get an alternate internet supplier, that would be better. I can hardly hear you. Yes, but while we're waiting for Ms. Achinoye, hello. Ms. Achinoye, I'm not sure we'll be able to take the presentation. It's breaking so badly. We can hardly hear you. But while we're waiting, while we are on that, I want to ask a question. If we can give our insights on that. When we have a situation such as a baby who is less than 3 months of age, and they are very poor and do not have access to substitutes like naan. Dr. Salam, you mentioned something like locally available alternatives. I would want to crave the indulgence of all the other panelists. If you have suggestions for these locally available alternatives. Like Matilda said, sometimes it can be pretty difficult for individuals to get these other substitutes like naan, and yet the child is less than 3 months of age. What would you advise for nutrition?
No, when you have listened to my presentation, I'm talking about locally available substitute in terms of complementary feeding. I'm talking about using locally available food materials. I wasn't talking about substitute for what do you call it, for breast milk or breast milk substitute.
Oh, okay.
Because quite all right,
that brings us back to that question. In my center, we've had situations like that. they cannot afford naan, and even if they can afford naan, they do it maybe a few, or they start diluting it. Do we have any suggestions for?
Honestly, it's all or none when it comes to the issue of either breast milk substitute or breastfeeding. If they cannot afford breastfeeding, all efforts should be made to encourage the mother to remove all those impediments that actually stop the mother from lactating. Maybe if the need of attaching the mother with lactation specialists, as I've highlighted in my lecture. Okay, improving the maternal nutritional status, counseling the mother if the mother is depressed or she is disturbed about the condition of the baby. And you know, if somebody is psychologically disturbed, no matter how much he eats or she eats, not even a drop of milk will come. So I think, those impediments need to be removed. If as long as that mother is to actually lactate, because it is easier for those problems to be solved than telling the mother to go and buy breast milk substitute, because the efforts may not be applied there. The availability, affordability, okay, accessibility, feasibility, and safety of the BMS. Just as he has said now, some will end up diluting the infant formula, for which the whole aim is now what? Is now being defeated. And this baby will still end up taking just water, thinking that it's taking milk. So before you know it, the anthropometric parameters of this baby will start going down. Infection will start invading this particular baby. And before you know it, the baby may succumb. Not even talking to withstanding surgery. So I think it's either all or none. If the mother cannot produce breast milk, but her reasons for not producing breast milk are surmountable, we should try in helping her to surmount those problems. If they are not surmountable, then actually support groups like what Smile Train is doing here in Kano, in terms of supporting those indigent mothers with BMS should actually be adopted. I think that's the solution.
Okay, thank you very much, Dr. Salam. Matilda, maybe like 2 minutes comments on that. Okay, Matilda is not here. Miriam, do you have like maybe 2 minutes comments on that?
Yes. First of all, I want to strongly agree with what Dr. Mohammed is highlighting. We try as much as possible to be able to reinitiate breastfeeding, support the mother through breastfeeding, or at least breast milk production so that they can be able to express. But in situations where this is totally not an option, or like it has been left out, like assuming a mother is presenting to you at 4 months, has never breastfed because probably they felt like they cannot breastfeed this baby with a cleft, and breast milk production has really gone zero, or they do not have milk at all and have initiated other forms of feeds. For such a case, we thankfully have a Smile Train that is able to support us with nutrition grants to be able to procure and get such options for these children. However, in some cases where it is not available or not an option, an immediate solution would be to be able to still provide this child. What we do is we can be able to modify cow's milk into a formula that can be used for these babies. For instance, we cannot provide full strength cow's milk. Some others still come while they have provided that, but we dilute it to half strength, and we're able to add in some sugar and some oil and let it boil, and pasteurize it to a temperature that is safe for the baby, to the sense that it has killed all the harmful microorganisms. But again, to that mixture, we can add some mineral and vitamin mix. However, it is not as strong or as beneficial as breast milk would be, or formula milk in a case where it would be available. But it is an option that can be taken in for such babies. We add the sugar and the oil to be able to just increase their energy value, so that this child, much as they are taking that formula, can still be able to meet their energy needs. And we increase the micronutrients and vitamins just to be able to still support their immune system, because again, it is not breast milk that has the antibodies to protect them, but that just helps to slightly boost their immunity. So I would give that as an option. It's better off than when we introduce other foods like mashed foods or porridge at that young age, less than 6 months. Thank you very much.
Thank you, Ms. Miriam. And I also want to use this to thank all of us, the panelists, the participants, for making time out to attend this presentation. While I'm on that, I want to invite our able comrade, Olubumi, to please come in and give, in our last 5 minutes or so now, to give our vote of thanks and her comments. Comrade Olubumi, you're on.
Thank you so much, Dr. Ade. Wonderful section, I must say. Wow, wonderful. Thank you. I've really learned a lot, and I also know that you have also learned 1 or 2 things. Thank you so much. To our esteemed panelists, you've been so wonderful. Thank you. We've learned a lot from you. And of course, to our for our host, Smile Train, what can we do without you? You've been handsome all over the world. Thank you so much for always being there to support our children without leaving no one behind. I would say that I just quickly also want to mention that, yes, comprehensive cleft care, as we have learned today, is a consortium of, or a full package of care, not just surgery, because most of our parents, our mom, our caregiver, always think that the only problem that a cleft child has is surgery. And once surgery is done, they are okay. But it's beyond surgery, like we've learned today. It goes beyond that. So Smile Train is actually supporting us to build capacity, local capacity, for us to be more responsive to children and adults that have cleft lips or cleft palates. In area of diagnosis, of course, feeding is critical, is the foundation of all. We've learned that. In the area of surgery, dental care, ENT care, speech therapies or speech services, the orthodontic services, counseling and support care is also very important. And that is why I want to say that it's very important that when we have caregiver or a mom who have a child with orofacial cleft, the first thing we need to do is to gain their trust, give them maximum psychological support, follow them up as appropriate, teach them, help them to believe. You know, most of these things at times, even without Palate, they still think they can't do that because of what they've heard from their environment, from the culture where they found themselves. But building their confidence and letting them know that, yes, they are not alone in this, that they can do it. We are always available to support them to do that. That will really also boost their confidence and their self-esteem to be able to support these children. And I will say that I also want to crown up to say that, yes, without you, the participants today, we actually will not be able to say we have done anything. Thank you, all our participants, for joining us. And please just look forward for our next segment on telecleft. Thank you and God bless you. Over to you, Dr. Ade, as we round up.
Thank you so much, comrade. And I make a resounding thank you, following up with Comrade Olubumi's thanks, and we'll bring today's telecleft to an end. Thank you, everyone. Bye-bye.